All right, hello and welcome everyone. I'm Dr. Tom Chaney and this is Living Health Live. Joining me on the show as well as in life and in our practice, Living Health Integrated Medicine, is my wife, Dr. Stephanie Chaney. We are your trusted source for the latest information to help you get and stay healthy naturally. I'm very excited to be joining you and taking you on this adventure of a lifetime, your lifetime of great health. You're going to get some great information, health strategies, and the latest research on how to live a better and healthier life. Just keep in mind, the information on the show is intended as educational and informational only. The information given here is designed to help you make better health decisions and not intended as a substitute for medical treatment. So on today's episode, we're going to be discussing gluten sensitivity beyond the basics, and we have a special guest. Dr. Steph, you want to introduce our special guest?
Yep, we are here today with Dr. Sam Sunshine, best name ever, medical director and founder of OC Sports and Wellness, a direct primary care clinic in Orange County, California, Sunshine State. A graduate of USC School of Medicine, completed his residency in family medicine and a sports medicine fellowship at Kaiser Permanente in Southern California. Dr. Sunshine specializes in functional medicine with a strong emphasis on prevention, focusing on the 5 pillars of health: sleep, exercise, nutrition, social engagement, and stress management. He also treats sports injuries using PRP and prolozone injections and offers peptide therapies to support optimal health and performance. Welcome, Dr. Sunshine.
Thank you so much for having me.
So we brought you here today. Gluten is a topic near and dear to our heart. We obviously wrote a book on it. We've been practicing functional medicine as well. And I really look forward to hearing another provider's clinical experience and expertise with regards to how to deal with this. And it's been an interesting, I would imagine you've seen the same thing over the last 15 or 20 years, evolution of the popularity of going gluten-free, or what that means, but there's still a lot of misinformation and confusion and whatnot around the topic of gluten and how to deal with it in a practice setting. So one of the things I hear a lot when we go out to dinner, for example, or to a restaurant, is the server will ask if we order something gluten-free, do you have an allergy or a sensitivity? So why don't we just start off with asking about what the difference is. What is gluten sensitivity, and is it an allergy per se? What is all that lingo?
Yeah, so great question. What's the difference between an allergy, immune reactivity, sensitivity, intolerance? There's really 3 categories. One is reactivity, or like an immediate reaction to a food or a medication. We use the term anaphylaxis for that as well. And that's usually an IgE mediated, which involves histamine release. You get swelling, hives, and that can be potentially life-threatening. And there are certain foods that are the most common: tree nuts, sometimes shellfish, crustaceans. Anyway, there's like the top 8 that can cause that. We don't see that very often, fortunately. The next one is a food intolerance. And the one example that I always use that a lot of people resonate with is lactose intolerance. So lactose is a sugar in milk, and about 70% of adults no longer make the enzyme lactase, which is a brush border enzyme that breaks down lactose. And so that undigested carbohydrate gets to the colon, where the bacteria feast on it and make gas. And so it can cause pretty acute distress for a lot of people when they have dairy. There are some people who can tolerate it and still make lactase into adulthood, but the majority of people worldwide do not make that enzyme after infancy.
We're not supposed to, right?
And we're not supposed to.
We're supposed to wean and get on with it.
Species that drinks milk after infancy, and we drink another species milk, and I think I've always thought to be very interesting. So that can lead to diarrhea and bloating, gas, pretty acutely, and that can happen within an hour to a few days. And then the third category is food immune reactivity. And this is tricky because this is not stuff that's taught in medical school. I don't think even today it's not, and it certainly wasn't when I was in medical school. And this is where we develop antibodies against food. And it could be food that is still in the gut, or it could be food that gets into the circulation through leaky gut issues. And so food immune reactivity is usually more of a delayed reaction. And the classic example we use is gluten as a food that a lot of people react to. It's probably one of the more common foods that can cause damage to the tight junctions. It can also cause immune response in the gut and also in the circulation. And that's usually delayed, but it could be within hours to several days later.
That's why it's so tricky to pin it down for people, because it might be something they ate 4 days ago and all of a sudden they wake up. And what would be some classic gluten delayed type symptomatology?
Yeah, so another great question. This is going to be classic for any of the food immune reactivities, but it could be brain fog, could be joint pains, neurologic things, again, not only brain fog, but headaches, skin rashes like eczema, dry skin, gut symptoms, of course, bloating, gas, reflux. And then it can also affect mood. So anxiety, depression can be these symptoms. So again, we see these in our practice all the time. And it's always my first step is to look for triggers. Mm-hmm. Low-hanging fruit, no pun intended, is food. And then probably the most reactive food that we see is gluten, followed by dairy, corn, soy, and egg. And those are on Cyrex and array 4 with Cyrex. And they do have a bundle where you can get the array 2, which is intestinal permeability, dysbiosis, with the array 3X and 4, and they give a little bit of a discount. But that's what I would start with these patients that come complicated. They have multiple symptoms with multiple systems, and they've seen multiple doctors. And these are the ones we just salivate when they come in, because we're like, I know I can help you. I just got to figure out what the trigger is.
Yeah.
And the food is the best place to start in looking at intestinal fortitude.
And what is it about, what is gluten? Maybe we should just start with the basic. Idea. What is it?
It's a large protein. It's about 150 amino acids. And I think with hybridization and processing over the decades by farmers, that I think in the United States, we have higher gluten concentration in the foods, like the breads.
We've made fatter gluten. We've made fatter wheat.
Yeah. And so gluten is this long peptide, and it gives food that chewy consistency.
The binding.
And and I think if you mix gluten flour with water, it tends to clump. And so that's what gluten is. It's found in wheat, rye, barley. It's not just in wheat. And when we look at reactivity to gluten, it could be either just a wheat reactivity, could be a gluten reactivity, or it could be celiac disease, which is an autoimmune condition in response to reactivity to a gluten.
And that's where I think sometimes people get a little, I don't know, maybe blasé. Like they may not have celiac. Oh, I don't have celiac disease, so I don't have a gluten problem. But really, what do you think that the estimate of the percentage of people that have a gluten problem actually have celiac?
Yeah, so that's a great question. Celiac is about 1% of the population. That's generally what's echoed in the literature. But the incidence of celiac disease has increased 500% in the last 50 years.
What do you think the percentage of people with non-celiac gluten sensitivity? Where do you think that falls?
I don't know if we know, but I'm going to guess probably it's going to be between 15 and 25% of the population. And again, I'm just throwing out a number. I don't know, but I know it's going to be higher than celiac disease. And these other, it could be reacting to non-gluten peptides. So again, gluten gets broken down into peptides or smaller proteins by our digestive enzymes. And then so this gluten proteome, this test, the 3X, looks at these digested proteins, doesn't look at everyone. And then it also looks at non-gluten proteins. The wheat kernel has non-gluten proteins in there as well. And some people react to those.
And what is it?
It's not just gluten.
Yeah, what is it about gluten or the breakdown? Like, what makes gluten such a trigger for people? And why, how does it trigger so many different symptoms?
Yeah. And again, because it does get broken down,
Mm-hmm.
and I think peptides can be inflammatory. And our immune system doesn't recognize these peptides as being friendly. So they look at them as being foe, and so they react to them. And it could be that just gluten's in higher concentration in the wheat or in the foods that are processed in the United States versus other countries. And then I know one of the questions that will come up later is, could glyphosate be playing a role as well, or other things that might be attached to these peptides forming neoantigens? And I think that's possible, but I don't think our bodies are reacting so much to the glyphosate. And I know that's a question for later, but I won't talk about that right now. But
Okay.
What is it about gluten that really is so reactive? And I just think it's the molecules, these breakdown peptides are recognized as being foe by our immune system, and we lose food tolerance over time. And I think part of it is due to the high concentration of probably gluten in our diets.
So I've had patients come in and they've been tested, right? They said they've been to another provider and they've been tested and they don't have a problem with gluten. And then I look at the tests, and most tests, and you mentioned testing, you mentioned Cyrex Array 3, which we want to get into. How is that different than like conventional testing?
Like lab
That's such a great question, because most doctors will look for celiac markers. And the two that are most commonly is tissue transglutaminase. So they're just looking at total tissue transglutaminase antibodies, and then also antibodies to anti-gliadin IgA,
which is the main gluten.
So
that's how most labs test for.
Yeah, and those are the two tests that they'll get. And if those are negative, then you don't have a problem. This non-celiac gluten sensitivity is not on the radar of anybody in conventional medicine. This is much more common than celiac disease, and it can give you the same symptoms.
So most labs will test, like the main labs, the conventional labs, they'll test for one gluten marker, the alpha gliadin, like you mentioned, and they'll test for the tissue marker related to celiac. And so how does that differ from the Array 3X?
3X. So Array 3X is looking at not only gluten proteins, so like gluten and gliadin, and some of the breakdown products, like these 33 mer, the 27 mer, and these are the number of amino acids that we're looking at that are commonly the breakdown products or digested gluten. And then it also looks at these non-wheat or non-gluten proteins. And it also looks at antibodies against transaminases, but it breaks it down into transaminase 2, 3, and 6.
And what's a transaminase?
Transaminase is an enzyme that metabolizes these glutens to glutamic acid.
Okay.
But if you have antibodies against these transaminases, it's an indication of autoimmunity.
So these are our own proteins, basically.
Yes.
So that's how someone could go and not just have celiac, which is an autoimmune condition where the immune system's attacking their own gut lining, but maybe because of these different reactions to our various types of transglutaminase enzymes, we could have a different, completely unrelated or seemingly unrelated non-intestinal type of autoimmune condition.
Yeah, it's like another category of reacting to wheat.
Do you want to go through like a sample just so people can see?
Just like an analysis?
Because this is a panel we run on almost everybody. Our kind of standard panel for most food testing minimally is the large food Array 10, but the gluten, this 3X, and then we do Array 4, which you had mentioned. This is going to be a little hard to see, I think. There we go.
See. How's that?
Okay.
Is that better?
It's way better.
Okay.
All right. So if I'm looking at this, again, really to diagnose, just to take a step back, to diagnose celiac disease,
yes,
the gold standard is a jejunal biopsy where you go see a specialist and they biopsy the jejunum, second part of the small intestine. That's not done. So again, we rely on symptoms. We rely on blood tests. When we think about celiac disease, what I would commonly see on a 3X, I would see the second one down, the wheat IgA, out of range, and then the tissue transglutaminase 2, IgA, being out of range, that's a pretty significant indication of celiac disease, but it's not definitive because again,
two is the gut lining, right?
Yeah. 2 is gut lining, 3 is skin, and
Okay.
6 is nerve tissue.
Okay. So this is where you could almost even be a little bit predictive. For example, if someone tested for the transglutaminase 3, if they were genetically susceptible, they could be a person who might get rashes or eczema. And then if someone tested, if someone tested to IG6, they could be the brain fog. They could be neuropathy, possibly, but this is more of an autoimmune, like, generated condition. Yeah. So that would be like a neuropathy not caused necessarily by diabetes and high sugar, but this might be more of this gluten triggered type presentation. Yeah. Okay.
Non-celiac gluten sensitivity is the 4th leading cause of ataxia.
And you have to define
for viewers. Ataxia is not walking and not having good balance. I can't imagine a neurologist would know that. Again, not to put doctors under the bus, but this is the value of these tests can be so helpful.
Yeah.
And the treatment is basically removing the food. And
it's interesting you say that. We had a patient one year who, this is over a decade ago, he was a Vietnam vet, and he came to us, and one of his symptoms was he would wake up every morning and stagger around the house as though he was drunk for a couple hours. And then we ran this panel, and he had obviously the gluten situation. And when he took gluten out, and I didn't even know that was one of his symptoms, it wasn't what he came in for originally. But after we cleaned his diet up and he took gluten out, he brought it up. That's how he used to function. And that wasn't happening anymore. So he took gluten out and he wasn't staggering, like just wobbling without good balance, like he was intoxicated.
Yeah. And the other thing that I oftentimes want to see with the Array 3X2 is that Array 2 to look for gut permeability issues as well. But usually if it's an IgA, we think primarily it's going to be intraluminal and IgG more systemic.
So IgG more blood?
More. So if we're seeing some IgG, I also worry about, could this be somebody who has gut permeability issues?
Because that means
I do like to run those together. Yeah. Okay. Not always the case, because you can see IgA in serum and IgG intraluminal as well.
Okay.
But that can somewhat be helpful. But again, the nice thing about this entire test is it's not just looking at gluten, antibodies to gluten and glutenin and gliadin, but also looking at the non-wheat proteins. It also looks at a couple opioids. And I think you guys probably know about this, but it's always fascinating for patients. And whenever I'm talking to other clinicians, they're like, wow, I never knew that. Or they'll say, did you know that wheat has substances? And that's the gluteomorphin and prodinorphin. And that's tested. And if those come back out of range, it's an indication of what's called a wheat addiction. Now, milk also has a morphine analog called casomorphin. Yeah. And so the people that are elevated in these, you just kind of let them know, hey, you have an underlying wheat addiction. You're going to go through withdrawals when you cut out gluten.
And so it's not just like actual drug withdrawal to some degree, really, because they're completely addicted to it.
Yeah, it is. It's an addiction. And so with withdrawal symptoms that take about 6 weeks to overcome, and you got to really have a lot of hand-holding for those patients.
Okay, it's good to know.
And then real quick, just at the top, those wheat germ agglutinin antibodies. So if those are positive or out of range or even equivocal, that's an lectin allergy. So you want to remove lectins and agglutinins from the diet.
So when you see equivocal, so going back, you mentioned like the one marker you just mentioned is equivocal. What does that mean versus out of range?
So the equivocals are 1 standard deviation beyond the mean. And they took about 300 patients that were considered normal or healthy, and they were screened and paid for their serum. And then they developed a bell curve. And so equivocal is greater than 1 standard deviation above the mean, which is the 85th percentile. And then out of range is greater than 2 standard deviations above the mean for this group of patients or people.
Okay.
So for the patient, would you say that we need to remove I guess I'm thinking of other tests now, jumping ahead, but looking at, say if this person came back and all they had was equivocal, would you say you need to cut out wheat and gluten?
Yeah, so typically what I'll say, and this is an oversimplification, but if it's equivocal, remove the food for 3 months and then try a reintroduction. If it's out of range, 6 months, because I think it just takes longer to clear. And then you can either do one of two things. One is you can rerun the test, and usually we wait 6 months after the treatment protocol has been completed, because that's about how long it takes to clear the IgG, and then see if these are still out of range, and you would continue food avoidance. Or you can just go ahead and reintroduce foods. Usually if you would reintroduce gluten, let's say, for a few days, see how they feel, knowing that it could take to a week or so before they start to see symptoms. And if they tolerate it okay, then they can resume that. Some people will argue if you're out of range for these and it's really a lifelong avoidance. But I think that's a tough request for patients to say you need to avoid this definitely, because it could just be you've lost food tolerance because it's a big part of your diet. You clean it up, and then when you reintroduce something like wheat, it's not, you just try to explain to patients the importance of food diversity and not having the same food.
And not having a leaky gut, obviously. Get the barriers back up, then, because you shouldn't be reacting to any food, really.
Yeah, but gluten, dairy, soy, corn, those are just they're foods that have been probably modified, and I think that our immune system just sees them as being foreign often. So
the original test that you were talking about, or the typical conventional testing for gluten or celiac with the major labs, tests for what you called alpha gliadin, which is a breakdown protein from the big gluten molecule. And you talk a little bit about like the different gliadins and why someone who has lab testing for the alpha gliadin and it comes back negative, it doesn't necessarily mean they don't have gluten sensitivity or this delayed reactivity or non-celiac gluten problems.
Okay, so my suspicion is if you're reacting on the array-3X to one of the gliadins, whether it's the 17-mer, just looking at this, the 15-mer, I think there's a 21-mer, which is glutenin. But those are gluten breakdown proteins that are oftentimes culprits for non-celiac gluten
like
sensitivity,
gamma, omega,
or reactivity.
Yeah.
Yeah. And so I'm thinking if, let's say, that alpha gliadin 17-mer is positive for IgA, then I would suspect that if they got the standard Quest lab or LabCorp test for alpha gliadin IgA, that it would also be positive.
But if it was negative.
But is it possible for some of these to be positive? Yes, because looking at different size of these proteins or peptides.
So when you talk about, you mentioned a couple of times delayed reaction, right? So that's why it can be difficult to diagnose from a symptom standpoint. So what's the delay? Is it a 12-hour delay? Is there any research that you know of? Is it a week delay or?
Yeah, so I've heard a lot of different explanations on this, but I think generally it's several days. It could be up as soon as 4 hours, but it could be 4 days. And then for some people, again, I've heard even several weeks after ingesting before you develop symptoms. But I think it's going to be sooner than that, but it's not going to be like immediate.
It's almost like a flu ramp up to some degrees. Like people don't really become acute and contagious until a couple days down the road of exposure. It's almost that same type of reaction. And then how long after can, if they, for example, flare up or have a reaction, how long might they have that last, depending on what tissues being triggered? Or
yeah, it could be really based on how frequently they're ingesting that food. A lot of people, wheat and gluten-containing foods is a staple. It's part of the standard American diet.
We'll say somebody just goes off plan. I get this all the time. They just went out and went to the restaurant. And I only had one piece of pizza.
That's right. I remember hearing Tom O'Brien speak. He did a podcast or a series in probably, I think it was 2015 or something, but it was something about the truth about autoimmunity. I don't know if that rings a bell, but he was talking about celiac disease. And he said, even if you're cheating one meal a week, you won't be making any progress. And I think that's very true. So people have their cheat meals.
Yeah.
And if you've got, whether it's celiac disease or non-celiac gluten sensitivity, and you're having your cheat days each week, you're not going to improve. Again,